Mantle cell lymphoma, again, is a complicated landscape and a complicated type of lymphoma. So in the upfront setting, there are a variety of factors to consider. So the patient's age, comorbidities, and also what's driving the lymphoma. So whether they have an abnormality in P53. And I think in that landscape, the options include high-dose chemotherapy with or without autologous stem cell transplant. And then also for maybe older, less fit patients, bendamustine with rituximab, like regimens. For a rare subset, watch and wait is appropriate for mantle cell lymphoma. That's much less common than the other potentially indolent types of lymphomas. In those with P53 abnormality, I really feel that clinical trial participation is critical. There's a lot of studies ongoing looking at the use of novel targeted therapies, BTK inhibitors, for example, in addition to frontline therapy or even combination with BCL2 inhibitors and CD20 antibodies in the frontline setting for patients that have P53 abnormalities. Because we know even with intensive chemo and transplant and maintenance rituximab, which in some patients there have been demonstrated, an overall survival benefit of adding maintenance, even with that more aggressive approach, patients with P53 abnormality, they don't do as well. So that's really the area of unmet need. And for those patients, even in the frontline setting, I strongly encourage and look for clinical trial opportunities.